Hi, Adult Health 1 students. This is module 3 already. So we are going to be going over, it's chapter 11, pain management, chapter 12, complementary and alternative therapies, and then chapter 20, patients with connective tissue disorders. This slide PowerPoint is only 60 slides, so it's not too crazy. So hopefully we can get through it. These are our objectives. This is about pain management. So the International Association for the Study of Pain defined pain as unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So in short, that's saying you can have a physiological cause for pain, but you might not. And that's okay. That doesn't take away from the fact that you're experiencing pain. Assessment and treatment of pain is challenging. No one person experiences pain like any other, and the same person may experience pain in different ways at different times and under different circumstances. Pain is very subjective, so we are at the mercy of how the patient describes that pain to us. We can look at the physiological cause and kind of know where we expect that pain to be, but there's a lot of factors that go into how a patient perceives and describes their pain. The peripheral nerves that innervate peripheral tissues have several unique features that allow them to sense and transmit information rapidly across great distances on their way to the spinal cord and brain. Each nerve is composed of a bundle of single nerve fibers surrounded by connective tissue. Each nerve fiber is a long projecting axon for a single nerve cell or neuron leading to a cell body located near the entrance to the spinal cord. Some of these single projecting axons transmitting incoming sensory or afferent information, especially those innervating the distal extremities, can be several meters long. Along the dorsal side of the spinal cord, the cell bodies of these peripheral neurons are grouped in a nodular structure or ganglion called a dorsal root ganglion. Each DRG, or dorsal root ganglion, represents a large region of the body, and the chain of DRGs along the dorsal side of the spinal cord represents somatic regions or dermatomes on the body. Dorsal root ganglion neurons are specialized at their terminal ends along their axons and in their cell bodies to respond to different sensory stimuli. So you don't have to memorize all that or anything. Just know that pain is directly related to the sensory stimuli received by the CNS. And if you have never seen a picture of like the CNS all laid out, all the neurons and whatnot, how they spread off the spine, Google that because it's super cool, and I feel like it gives you a whole different perspective of how the central nervous system just kind of takes over the whole body, right? This next slide is a picture out of our book. It's figure 11.3. It just talks about like where the dermatomes are, how the CNS kind of spreads out through the body. So it's a nice little diagram. Take a look at that. This one is just a picture also straight from the book, but it shows how sensory starting like in the finger, like if you hurt your finger, how it travels through the spinal cord up to the brain, and then the brain perceives whether or not you have had pain or not, right? So that's kind of a nice little diagram. All right, chapter 6. Recent data demonstrates a complex interplay among biological, physiological, psychological, and social factors on individual differences in the experience of chronic pain. So all that's saying is all the factors that go into being a person play into how we perceive and feel chronic pain. Some people seem to have a lower threshold for pain, whereas others appear to tolerate a great deal of pain in spite of common anatomy and physiology. Evidence suggests many factors shape the pain experience. including prior experience with pain, expectations of pain and anxiety, and as well as attention to and the situational meaning of that pain for that particular patient. A patient in labor, for example, may be able to endure quite a bit of pain, knowing that at the end of this painful experience will be a new life. The same patient in labor, however, may find labor more painful in a subsequent delivery if they have had a difficult delivery with a previous birth. So basically they're saying our previous experiences with pain can shape our future experiences with pain. Sociocultural determinants of pain. One of the most powerful influences on the pain experience is the patient's cultural experience. Social norms and customs shape families. The communities of residence and the large culture just as larger culture communities and families shape biology and behavior. People learn how to respond to pain in subtle and obvious ways. In some families, stoicism is valued, whereas in other families, it is acceptable to more demonstrably, that's the word in the book, display pain. So be more demonstrative in your display of pain. Be more over the top, right? Depending on how health and illness are defined within a community, pain may mean different things. A patient's cultural experience may lead to increased faith in Western medicine to diagnose and treat pain, whereas another patient's experience may reinforce non-Western approaches to managing pain. Limited access to healthcare resources may inspire creative and folk solutions to pain that continue even when access to healthcare is ensured. You know, we talked a lot about that when we were talking about cultural considerations, right? Also, sex and genetics play into the perception of pain, or can influence pain. The term sex refers to purely biological differences between males and females. The term gender encompasses the larger psychosocial cultural context associated with being masculine or feminine. As such, differences between male and female patients may represent clearly distinct molecular and neurohormonal pain mechanisms, whereas gender differences may reflect the influence of a wide range of cognitive, affective, and sociocultural factors. Modeled and learned behaviors, life history, and factors other than biological differences may influence both pain processing and the pain experience. Gender role experiences, for example, may discourage men from reporting pain or even seeking regular medical care. On the other hand, women are statistically more likely to have an ongoing relationship with a healthcare professional and may feel free to report painful symptoms. Sex and gender differences have also been noted in response to analgesics. Several studies of hospitalized post-op patients using PCAs, so patient-controlled analgesia, found that male patients require higher opioid doses to achieve pain relief than did female patients. Epigenetics and pain. Epigenetics refers to the cellular processes that allow access to the cell's DNA for transcription, regulation, and production of proteins critical to cell function. Two of the most therapeutically intriguing insights arising from epigenetics research are suggestions that epigenetic mechanisms play a critical role in the transition from acute to chronic pain, and that a wide range of environmental factors across the lifespan serve as epigenetic primers for individual pain and analgesic response. Evidence suggests that more than 1,000 genes in spinal cord neurons are epigenetically regulated within the first minutes to hours following a peripheral nerve injury. So again, think about how complex a process that is, like how much it involves. All right, so we need to talk about pain in older adults. So the pain assessment tools used in most healthcare settings were developed and tested with younger adults and may lack reliability and validity as pain measures in older adults. For example, evidence suggests that verbal descriptor scales and numerical rating scales become more difficult to use as patients age, with a higher frequency of incomplete or unscored responses. The evidence further suggests that older patients who are not acculturated to visual analog skills or numerical rating skills in their formal education, or who may have mild to moderate cognitive problems, demonstrate problems reporting their pain using tools that require a level of abstract reasoning. Some older patients with pain reluctantly report pain, feeling as if pain is to be expected and normal, or out of fear that pain signals pathology, leading to a diagnostic process that itself may be painful. So older people may not want to report pain because they may think, if I talk about that, then that's a bigger problem, and that's going to lead to even more debilitating pain, possibly, right? And a little bit understandable there. The differences between older and younger adults are most apparent in acute pain, especially acute pain associated with specific injuries or infections. Conditions that are painful in younger adults, such as urinary tract infections or duodenal ulcers, are likely to manifest as subtle behavior changes in older adults, including confusion, aggression, restlessness, or a loss of appetite. And we talked about that previously as well. The pathophysiological reason for this more subtle clinical presentation is not clear. It is theorized that age-related changes in these target organs or in pain processing structures in the spinal cord and brain lead to an altered neurochemical response from sensitized nerve cells. So basically your nerve cells are not functioning like they should. Shocker, right? Because what have we learned? As you get old, everything kind of stops functioning the way you would expect it to. Instead of pain messages moving along established pain pathways, new synaptic connections are made that divert pain messages to other brain regions. So as the signal gets diverted from, through the CNS to the brain, maybe the pathway is different now. So instead of where that pain signal normally goes in the brain, it goes to a different region. So then if I'm going to a different region of the brain, that region of the brain is going to process different than the original region, right? So they think that is what may be behind seeing the behavior changes in older adults versus the normal signs and symptoms that we would expect. All right, this is comprehensive assessment strategies. Pain specialists use the 0 to 10 pain rating system as contributing to both the sorry, I'm reading this wrong. Pain specialists implicate, so they're blaming, the 0 to 10 pain rating system as contributing to both the overprescribing of opioids and the larger opioid misuse epidemic. A new consensus is developing that measuring intensity is the only way to assess pain and analgesia response, and that the most effective pain assessment approach is to assess across multiple dimensions of the pain experience. So instead of just going 0 to 10, we're going to take other things into consideration. Examples of unidimensional assessment tools include the numeric rating scale, so unidimensional, one-dimensional. So numeric rating scale, 0 to 10. Verbal rating scales and visual analog scales. With these, one end of the scale is marked no pain, and then the other end is worst pain ever, or uses kind of a similar phrase to indicate intense pain. Often the patient is asked to evaluate the pain on not just one visual analog scale, but several similar scales to assess different dimensions of pain besides intensity. Some of these other dimensions of pain include how disturbing or unpleasant the pain is, how close to the surface or how deep the pain is, and how disruptive the pain is to activities of daily living. Another useful approach to visual analog measures is to use cartoon faces, expressing degrees of discomfort, unhappiness, and pain. These are those Wong-Baker faces. I'm sure you've seen them. It's like the different smiley faces. And of course, the last one is not smiling at all because that is the worst pain possible. So physical assessment of pain, we use the OPQRST and then the AAA. So physical assessment. The most useful of these techniques for bedside clinicians may be palpation and assessment of range of motion. Muscle groups in the area of pain should be palpated, and both verbal and nonverbal response to this palpation should be recorded. Have you ever seen somebody, you like push on something and they totally grimace, but they're like, no, it's fine, right? Obviously their facial expression is saying it is not fine. Or if they pull away, not fine. So what we're doing is just balancing between what they're telling us versus what their nonverbal is telling us. Clinicians should also record responses to any assessments of joint flexion, extension, side bending, and extremity lifting to determine whether pain is experienced with movement or whether there are any functional limitations. So is your range of motion being affected, right? Consultation with members of the health team may lead to more extensive bedside testing, including a tailored neurological examination consisting of cranial nerve assessments and sensory testing of sensitivity to light, touch, pressure, and pinprick, as well as reflexes. A more extensive assessment of motor function may include tests for motor weakness, coordination, balance, and loss of endurance. So we're just trying to figure out what all this pain is affecting. All right, when we're talking the OPQRST and then of course AAA, you guys covered this in fundamentals. So O, onset of pain, P, provocation, there we go, provocation. What causes the pain, right? What provokes it? Q, quality of pain, R, region and radiation, S, severity of pain, T, time and duration, and then the AAA is aggravating and alleviating factors and associated clinical manifestations. So like with this neck pain, do you also have a headache? Do you have tingling? Do you have loss of sensation? So what else is going on? If you are unfamiliar with those, I copy and pasted the speaker notes straight out of the book. So just go ahead and review those. Nursing management. So effective interventions begin with comprehensive assessments of clinical manifestations of pain. So what are our signs and symptoms, as well as functional health patterns. Specific tools or inventory forms are regularly used to collect initial or baseline data that establish physiological stability, the risk for physiological instability, and patients' habits and routines. Questions that determine activity and exercise patterns, sleep-rest patterns, role and relationship patterns, and coping and stress tolerance patterns help nurses understand the larger impact of symptoms such as pain. This subjective portrait of a patient's health status is combined with physical assessment findings and other objective data to drive the identification of priority nursing diagnoses and a comprehensive plan of care. For patients in pain, the impact is far-ranging. The activation of pain processing networks in the brain and spinal cord engages hormonal responses and stimulates sympathetic and parasympathetic nervous system responses. Elevations of the heart rate and blood pressure may be seen as a result of pain, which can exacerbate pre-existing health conditions such as heart failure or kidney impairment. Pain may limit the ability of someone to work or engage in previously enjoyable social situations. Pain may limit partner intimacy and alter interpersonal relationships. Pain may cause patients to question their beliefs, their values, and their self-worth. Pain may disrupt sleep or affect a patient's appetite. Pain medications may alter elimination patterns or compromise the physiological integrity of vital organs such as the liver or kidney. In order to develop a comprehensive plan of care for the patient in pain, it is crucial to once again review how clinical manifestations affect functional health patterns. The nurse must provide both targeted pain medications and non-medication-based therapies designed to address the pain, such as thoughtful positioning and appropriately resourced assisted ambulation that promotes effective pulmonary hygiene. When we say pulmonary hygiene, You'll also hear like pulmonary toilet, believe it or not. That just means that we are doing things like keeping the mouth clean. We are suctioning as needed. We are doing stuff like ambulating to keep our lungs, all the fluid in our lungs, moving and nice and clear. So that's pulmonary hygiene, taking care of your respiratory system. The nurse's role in intervening and advocating for effective pain management depends on understanding the broad range of treatment options. So there's lots of stuff we can use to treat pain. First, we have non-opioid analgesics, right? Medications that reduce pain sensations without also inducing a loss of consciousness are called analgesics. The most common analgesics are non-narcotic and non-opioid. This classification of pain meds includes 3 general categories of medications. So salicylates, which is aspirin, acetaminophen, which is our Tylenol, and NSAIDs. Probably ibuprofen is most common. Aspirins and NSAIDs are believed to reduce pain largely as a result of inhibiting local prostaglandin synthesis. The rapid elimination of ibuprofen from the body means that it is safe to use for most patients, even those with severe liver impairment, but should still be used with caution in chronic kidney disease, especially in older adults. The kidneys may not be able to filter out the NSAIDs as effectively as needed. Okay, so you can end up with a buildup. Acetaminophen has a similar analgesic effect as aspirin, although acetaminophen has few anti-inflammatory effects. So acetaminophen is not really an anti-inflammatory, whereas NSAIDs are, right? That's why a lot of times you'll see people use acetaminophen and ibuprofen together. Ibuprofen is the one that has those anti-inflammatory effects, and then acetaminophen works on the pain. So acetaminophen is metabolized in the liver and excreted in the kidneys. When used at therapeutic doses, limits of 1,000 milligrams per single dose and 3,000 milligrams in 24 hours, acetaminophen is generally safe for use in patients with healthy livers. Doses need to be adjusted for patients with liver impairment or not used at all. So acetaminophen, we need to watch with our liver and kidney, and ibuprofen is primarily just kidney, okay? Extra precautions need to be taken to educate patients about taking over-the-counter acetaminophen with any other over-the-counter or prescription product. Patients may not be aware, for example, that over-the-counter cold preparations and prescription pain meds such as Tylox and Vicodin also contain acetaminophen. The risk of accidental overdose leading to liver failure has been associated with cumulative acetaminophen doses of greater than 3,000 milligrams per day. So one of our teaching aspects is really going to be, if you are taking acetaminophen, make sure whatever else you're taking, you are double checking that there is not acetaminophen in that also. That's huge with like cold medicines, and then of course you get those combo pain meds. You know, like the Vicodin in particular. We may also use corticosteroids for pain. Corticosteroids are going to work on that inflammation, okay? Corticosteroids are naturally occurring steroid hormones produced in the adrenal cortex. These steroids are involved with the body's stress response to illness and injury and play a role in the body's immune response and inflammation. Synthetic steroid hormones such as prednisone and hydrocortisone are used as anti-inflammatory agents to treat arthritis, bone pain, and painful dermatitis, as well as visceral pain conditions, including lupus, sarcoidosis, and inflammatory bowel disease. They are also successfully used to treat acute inflammation and pain following nerve and spinal cord injuries, and are used as adjuvant, increasing effectiveness of other medications therapy for pain control in cancer patients. So basically what that means is we use steroids with other pain meds for a synergy response, right? They work together to further decrease that pain. Corticosteroids can be delivered at low doses in topical creams, ointments, and drops. Higher doses can be given orally, inhaled, directly injected in targeted regions such as joints, or delivered intravenously. Secondary effects of steroid use include improved appetite and mood, which can also shape the pain experience. High dose or sustained steroid use is associated with several side effects, though, including hyperglycemia, weight gain, myopathies, and Cushing syndromes, as well as mental status changes, including delirium and psychosis. I will tell you, when you are in a hospital setting and we have patients on steroids, we'll do blood sugar checks on them. And you're going to have to do teaching with either the patient and or the families, because they're going to be like, well, I don't have diabetes. Nobody told me I had diabetes, right? And it's not that they have diabetes. It's just that when you're on steroids, they can cause hyperglycemia. So we want to monitor that, right? And, you know, you may or may not have a sliding insulin scale to administer, but that's definitely a conversation you end up having with people. So just remember, it's related to the steroids, not that anybody thinks you're developing diabetes. You know, and also in a hospital situation, the stress of being in a hospital, you know, that affects how the body is processing everything, including sugar. So it's not uncommon, related to the high stress of being in hospital, that you can have patients be hyperglycemic who also do not have a diabetic diagnosis. So you couple that with steroid use, you know, kind of a double whammy, but we want to be watching that, that sugar. Corticosteroids should not be used in combination with NSAID to minimize the risk of GI bleeding, especially in older adults and our anticoagulated patients. So that anticoagulated patients, that's going to be our people on blood thinners, right? Local anesthetics. Local anesthetic agents are pharmacological substances either topically applied or injected into nerves and tissue that eliminate sensation and pain without the loss of consciousness associated with general anesthesia. Local anesthetics are generally used in a defined location to accommodate minor surgery or to regionally target pain. Lidocaine is the most commonly used local anesthetic medication. Local anesthetics relax vascular wall muscles, bringing increased blood flow into the region. The increased blood flow can increase systemic medication absorption, which shortens effective anesthesia times. To maximize local anesthetic effectiveness, these anesthetic agents are often combined with short-acting vasoconstricting agents such as epinephrine. So what they're saying is that we know that these anesthetics will open up the blood vessels, right? But that can cause the anesthetic to not last as long. So what we do is then we give you some epinephrine, which is a vasoconstrictor, so it goes and closes down all that opening. Okay, so we still get the effect of the lidocaine, but it doesn't work against us as far as its efficacy being reduced, because now we have all this blood flow, right? So if we have extra blood flow, it's going to disperse faster, right? It's going to move through the system quicker. So we shut that action down by giving something like epinephrine, which constricts, okay? This allows the anesthetic agent to stay regionally active for a longer period of time and limits potential systemic toxicity from too rapid absorption. Local vasoconstriction also reduces bleeding in the area of injection. Epinephrine-lidocaine combinations, however, are not recommended for small, confined, vascular-rich areas such as the penis, fingers, or toes, where local vascular constriction can cause inadequate blood flow and tissue necrosis. So we don't want to cause damage, right? Local anesthetics are also diluted and compounded into sprays, pastes, and creams that can apply to minor burns and abrasions. A commonly used mixture of local anesthetic is a combination ointment consisting of 2.5% lidocaine and 2.5% prilocaine, and is applied to provide superficial dermal anesthesia for venipuncture, IV catheter insertion, and minor wound debridement. It is applied 45 to 60 minutes before a procedure and covered with an occlusive dressing. EMLA provides up to 2 hours of local anesthesia once the occlusive dressing is removed. Dilute lidocaine anesthetic sprays and lozenges help soothe sore throats and aid in anesthetizing oral mucous membranes in preparation for tracheal or nasogastric intubation. We also have topical rubefacients. Rubefacients are topically applied substances that cause local dilation of blood vessels and reddening of the skin, producing local sensation of coolness and warmth that many people find soothing. Examples of rubefacients include rubbing alcohol, menthol-containing ointments and creams, salicylates, and oil of wintergreen. Products such as Icy Hot and Bengay, which contain menthol, and aspirin-containing creams such as Aspercreme and Myoflex, are used to treat low back pain and general muscle aches associated with activity. Rubefacients are often compounded to have a strong medicinal smell that is also believed to distract or offset the pain, and are the most widely purchased over-the-counter pain remedies after oral non-opioid analgesics. I thought that was super interesting because now you can buy like low odor Bengay and all of that stuff. So it's interesting that now you can get the low odor, no odor versions, but the fact that you could kind of smell that menthol action is really part of the pain working against the pain. So it's kind of funny. I'm guessing most people are not aware of that. So rubefacients should not be used to treat painful dermatitis. Dermatitis following radiation treatment, because radiation damages epithelial cells and alters the permeability of the vascular bed, and the use of topical rubefacients can worsen radiation-induced dermatitis. So basically, you've already got damaged skin and kind of broken skin really after radiation. It's very sensitive. So we don't want to go putting topicals on top of that. Capsaicin, which is a topical rubefacient, the active ingredient is chili peppers. So capsaicin is frequently used in topical ointments and dermal patches to produce localized soothing warm and hot sensations. Just imagine though that if you've ever had a burn, in your skin, once the blister has come off, it's kind of tender before the blister appears. Imagine if you put something with chili peppers on that damaged skin. So that's what it would be like if you had radiation burns and then you use something like this. One of these rubefacients, it's gonna burn like crazy, right? And cause damage. So capsaicin is believed to activate specific temperature-sensitive receptors on peripheral neurons, causing a rapid propagation of warm and hot impulses to the spinal cord. At the level of the spinal cord, these heat impulses cause rapid release and emptying of stores of a pro-pain neurotransmitter called substance P. Until these neurotransmitter stores recover, which could be as long as 6 to 8 hours, these particular peripheral neurons cannot induce a pain response. Isn't that crazy? In patient comparison studies, the evidence in support of capsaicin heat for providing effective pain relief is stronger than for the heat produced by other rubefacients. At low concentrations, capsaicin, this is, I don't know if you've ever seen Tiger Balm, but capsaicin is in Tiger Balm, is used to treat minor musculoskeletal aches and pains, including arthritis, backaches, muscle strains, and sprains. At higher concentrations, capsaicin-containing ointments and patches have been used to treat the post-therapeutic neuralgia associated with shingles, as well as other peripheral neuropathies. Gloves should be worn when applying capsaicin ointments and patches to avoid clinician exposure. Basically, if I put capsaicin on my hand, do I want to go and then put in my contact lenses? No, I will burn my eyeballs out, right? So if you wear gloves, it keeps you from spreading that hot chili powder heat to other areas like mucous membranes that you may not want it, right? So at higher doses, face masks may even need to be worn, protective eyewear, and gloves. Capsaicin creams are not recommended immediately after hot baths or showers, right? You've already got that vasodilation going on, so that could really exacerbate that. Nor are they recommended to be used with heating pads because the additional heat may allow for overabsorption of the medication. So capsaicin basically is its own heat source, and it is good all on its own. We don't want to combine it with anything. This is a safety alert out of your book. Just take a look at this. This is the one that talks about making sure to use acetaminophen safely and to double check that acetaminophen is not in any other things that you are taking. Okay. It also talks about on here pain and fever, managing pain and fever during pregnancy. So take a look at that safety alert. This is table 11.5. This talks about common over-the-counter non-opioid analgesics. Talks about some of the risk factors that we need to pay attention to. Notice BUN and creatinine. BUN, creatinine, those are our kidneys. AST and ALT, that's our liver. All right. Notice that Toradol, ketorolac, has a tinnitus warning on there. We talked about what tinnitus or tinnitus is. And then, of course, with our aspirin, we are worried about signs and symptoms of a bleed. Okay, so take a look at this. Now we're going to talk about opioids. So opioids, considered primary in the treatment and management of acute pain. All right. Don't forget, we always talk acute versus chronic. So nowadays, we are very specific in saying that opioids are for acute pain. Opioids are among the oldest known substances used for the treatment of pain. It is increasingly recognized that opioids are much less effective in managing the pathologies underlying most chronic pain conditions, and their use in chronic pain should be carefully evaluated. It is the action of opioids on receptors in other brain regions, such as the hypothalamus and pituitary gland, that produces the autonomic effects seen with opioids. This includes pupil constriction, dry mouth, lowered body temperature, and reduced sensitivity to cold. Opioid activation of receptors in the brainstem mutes the activity of the sympathetic nervous system and causes relaxation, sedation, slowed breathing, and reductions in anxiety. Other effects of opioids on brain receptors activate the chemoreceptor trigger zones, which can induce nausea and vomiting. So basically, opioids can cause nausea and vomiting. You know a trick to that? You wave an alcohol pad under somebody's nose if they're feeling nauseous and you don't have an immediate prescription for or an order for Zofran. Opioids are used in the treatment of moderate to severe pain and are often administered to post-op patients. Although most often administered via the oral route in the outpatient setting, opioids may be given via the IV, subcutaneous, intraspinal, transdermal, rectal, and epidural routes. Oral dosages may provide the most consistent therapeutic levels of these medications if administered at appropriate intervals. Patients may not receive adequate pain relief because of a fear of side effects or fear of addiction, which is not the same as tolerance. So the definition of tolerance, tolerance is characterized by the need for increasing doses of medication to get the same pain results. So you need more and more of the medication to get you to that like level 2 pain, keep you at that level 2, right? Addiction is characterized by a compulsive behavioral pattern to take a medication for both its physiological and psychic effects without regard for the negative consequences associated with continued medication ingestion. So you're taking it for the high is what it is, right? The growth in addiction, particularly to new synthetic opioid formulations over the last 5 years, has reached epidemic proportions. There is existing evidence that opioids should not be initiated in the management of chronic pain, even for those at low risk for developing addiction. When already prescribed for chronic pain, a carefully individualized treatment plan should be developed, and while abrupt cessation or down titration of opioids should be avoided, Opioid antagonists can be used in conjunction with treatment of opioid use disorder if this is a concern. In the setting of acute pain, opioids should be used sparingly unless pain is severe, and then should be prescribed in short courses of less than a week, at which point reevaluation is advised. Patients receiving opioids are at risk for several side effects, particularly related to actions at the mu receptor. And prevention and management of these effects are central to any plan of care for patients receiving opioids. Respiratory depression is the most critical adverse side effect of opioids and requires close patient monitoring, especially after IV administration. The American Pain Society's 2020 guidelines for nursing highlight the importance of monitoring for sedation and respiratory depression in all hospitalized patients, with focused attention on those at high risk. Importantly, risk can be stratified across patients. So if you are dealing with someone who has impaired pulmonary, cardiac, or renal function, right, that puts your person at increased risk. Treatment parameters hours after initiating opioids in the naive patient, and across environment of care levels. So we are going to look at what's going on with our patient when we are prescribing, and well, we're not prescribing, I apologize, when we are administering, and helping to determine what dosages are appropriate for our patient. Opioids also carry risk for GI side effects. Nausea and vomiting are relatively common and usually develop shortly after the first doses. In the post-op patient, assessment for nausea and vomiting is particularly important because it increases the risk of aspiration, right? Our patient might still be coming out of anesthesia, so we don't want them to aspirate, choke, and die, right? Patients experiencing pain often have decreased physical activity and oral intake. These circumstances, along with the effects of opioids on the GI system, increase constipation. Laxatives and stool softeners are almost always indicated to assist in the prevention or treatment of constipation. Other receptor-mediated adverse effects of opioids include urinary retention and pruritus. Pruritus is just itching. Don't forget, opioids slow everything down, and that includes the motility of the gastrointestinal system. So you want to start all your stool softeners and all your bowel care stuff as soon as you put a person on opioids. Like, don't underestimate that aspect, because the last thing you need is somebody ending up with a bowel obstruction related to the opioids they were on for acute pain. So opioids acting on opioid receptors in synaptically reorganized dysfunctional pain pathways can paradoxically increase pain in patients with chronic pain. So when somebody's living with chronic pain, the pain pathways of the nervous system and the brain, they kind of reorganize, right? Because this is now a chronic situation. So your body's like, this is what we're doing now. And so you end up with physiological changes. And so what they're saying is actually these re-pathwayed pathways, opioids will not respond in the typical manner that we expect opioids to respond. And they can actually work against you in chronic pain due to the development of these alternate pathways. So we really have to take that into consideration as well, okay? And then imagine you're a chronic pain person, you've been prescribed opioids, you have alternate pathways that have developed because of chronic pain, your opioids aren't working. What is one of the first things that you're going to think about doing? Taking more opioids, right? So now you have unconsciously, unknowingly, I should say, increased your problem, right? So really, with chronic pain, we want a consultation with pain management experts. There are pain management specialists, and they work on using opioids effectively, using other pain management medications effectively, combining things so you get a synergistic effect to them, and also using alternative therapies to get an overall effect. All right, this is about a new opioid. This is straight out of your book. This is super interesting. There was a new opioid that they came out with in 2018. It's 10 times more potent than fentanyl. And keep in mind that fentanyl is 100 times more potent than morphine, and fentanyl is 50 times more potent than heroin. Okay, so this new opioid is 10 times more potent than fentanyl. And they decided with the opioid epidemic that it was really too scary to roll it out to the public. So a lot of times it is being reserved right now for like military use in the field, when it's not possible to get to a hospital or someplace closer. So this is just kind of an FYI, kind of interesting, kind of good example of how we are thinking differently about the strength of the medications that we roll out for general use, right? We're being much more conservative about that. So just take a look at this. It's kind of interesting. This is evidence-based practice related to opioid use and pain management. So this talks about opioids are effective for managing acute pain, such as post-op or trauma-associated pain. But has few therapeutic benefits for chronic pain. Most effective when combined with NSAIDs, and are most effective when combined with teaching and self-management. So we want our patients to be aware of expectations related to pain. Zero pain is usually not a realistic option. So we need to talk about that. We also need to talk about trying what is an acceptable level of pain. Is a 3 acceptable level? Maybe you've had chronic pain at a 10, and maybe a 6 is an acceptable level. So what can we do? How can we keep you there? And how can we use the least opioids possible? This talks about morphine. Morphine is the gold standard of opioids in the treatment of acute pain. Oral morphine agents are available in both short-acting and controlled release. In the acute setting, particularly with severe pain, and in the post-op setting, IV morphine is common. Hydromorphone, which is Dilaudid. Dilaudid is really not used all that often anymore. But of course, you hear a lot of jokes about people coming into the ED and they're allergic to everything else except Dilaudid, right? So Dilaudid is another opioid used in the treatment of severe pain. It's 5 times more potent than morphine. So it's not up to that fentanyl level yet, but it's stronger than morphine. It is available only in short release forms, and it's frequently used in the treatment of acute pain, particularly via IV. Fentanyl, roughly 100 times the potency of morphine, is another effective short-acting opioid available in IV form in the inpatient setting for acute pain. Its transdermal patch route is effective for longer-term management of severe pain, often in the context of cancer or other life-limiting illness. Synthetic opioids include different preparations of oxycodone, including the extended release form branded as OxyContin. When you talk about the opioid epidemic, you hear about OxyContin a lot. That was a very, probably still is a very, very abused drug. This potent opioid, although originally marketed as having low addiction risk, is highly addictive, given its low cost and wide prescriptive availability. Until recently, this single agent was identified as being the most commonly abused opioid and responsible for a significant number of overdose deaths. Appropriately prescribed to manage short-term acute pain, this medication represents a significant treatment advantage over other commonly prescribed opioids. However, tighter prescription controls have not necessarily reduced opioid overdose deaths. Patients who previously have been taking OxyContin and find themselves addicted but without a ready source of that medication have switched their opioid of choice to cheaper and often illegally obtained heroin and fentanyl. Opioid overdose deaths remain a significant public health concern. One of the things I know we hear about all the time is people taking stuff that is laced with fentanyl. And they die almost immediately because that respiratory depression is like bam, right? I mean, it's 100 times more potent than morphine. And we worry about respiratory depression with morphine. So if you take a big old dose of fentanyl and you are not expecting that, if you have not built up a tolerance, essentially, your body, you're dead, you're done. So it's definitely a problem. And then considering that, people hear about fentanyl use on the news and they hear about people dying from fentanyl. So if we are using fentanyl in the clinical setting, expect to have to do education related to the fact that, look, this is in a controlled environment by people who know what they're doing. This is not like buying fentanyl off the street, and it's not like getting a fentanyl dose that you were unknowingly receiving, right? Controlled environment, medical environment, it's a lot different. But be prepared, you're going to have those conversations with people for sure. After Michael Jackson died, he died while he was on propofol, and we use propofol all the time for sedation at our facilities, and we had to have the propofol chat all the time that like it's safe, it's okay, we're using it appropriately versus not using it appropriately, right? So that's definitely a teaching aspect you guys are going to run into. This is straight out of the book. This is figure 11.7. This is interesting. It shows where morphine is on the scale of potency, and then shows where the other medications fall related to morphine. So just take a look at this. Know that morphine is the gold standard for acute pain with opioid use. Atypical analgesics. So these are other things that we can be using other than opioids, right? Adrenergic agonist. So clonidine you're going to learn about in mental health, but clonidine is a direct acting alpha 2 adrenergic agonist, and it can work on high blood pressure as well, used for high blood pressure. So its side effects of analgesia and sedation prompted clinical trials to evaluate clonidine for pain relief. Oral dosing of clonidine for pain management has limited benefit for the treatment of acute and chronic pain because doses sufficient to produce pain relief create excessive sedation. However, intrathecal and epidural infusions of clonidine have been used to treat cancer pain and some neuropathic pains. So we may use it maybe not just in general as acute or chronic, but specific cancer or neuropathic pain. It can be very effective, right? Especially if patients have become tolerant to opioids. So rather than just pile more opioids on, we can use something like clonidine. They may also use tricyclic antidepressants and selective norepinephrine reuptake inhibitors, SNRIs. So tricyclics comprise a large class of medications that modulate the effects of serotonin and the related neurotransmitter norepinephrine in the CNS. So this was actually first used to treat mood disorders and major depression back in the 60s. They have become more widely used to treat pain with the discovery of the critical role of serotonin and norepinephrine in modulating naturally occurring opioids and descending pain pathways. So they kind of they give a boost to our system, our pain system that is already in place to avoid pain. So it kind of helps it along, right? So tricyclics largely affect the reuptake of serotonin or norepinephrine at the level of the individual synapse in the brain, with the net effect being an increase in the amount of neurotransmitter available. So it tells our brain to pull more of this stuff up, pull more of these natural pain meds up, essentially. The most commonly prescribed tricyclic is amitriptyline, Elavil, anafranil. You can take a look at that. For us, this is nothing you need to memorize, okay? Now, when you get into mental health and pharm, you're going to talk about the mechanisms of action and that sort of thing, and you will be putting these meds to memory at that point. Let's see. So these tricyclics have proven effective at managing neuralgias, fibromyalgia, and migraine headaches, and pain associated with irritable bowel syndrome, and even some post-traumatic stress disorders and neuropathies. Although doses for pain relief are generally lower than those prescribed to treat depression, the stabilization of mood that accompanies tricyclics used is generally viewed as a positive outcome for patients with pain who also report depression. So, imagine living with chronic pain. Do you think depression could be a thing? Definitely, right? So the benefit of tricyclics is it benefits the pain, but it also works on the depression. So it has a twofold effect, okay? Duloxetine, which is an SNRI, has shown potential benefits in neuropathic pain as well, and may be considered when treating concomitant pain and depression. Tricyclics and SNRIs are used commonly for neuropathic pain, but have varying efficacy across patients and are not without side effects. So there's considerations, right? We just don't go up and using these things without considering what the side effects may be. Equianalgesia. I'm going to be honest, I had never heard this word until our book, okay? But this talks about, it's a good concept to be aware of. So medications with different potencies and different mechanisms of action can often be used interchangeably to achieve similar levels of pain relief in case a patient's sensitivity or intolerance to medication effects or addiction is concerned. A 25 microgram per hour fentanyl patch will gradually release pain medication, providing pain relief for up to 3 days. This dose provides an equivalent level of analgesia as that delivered by 30 to 40 milligrams of morphine delivered orally every 4 hours over a 24-hour period. So basically they're saying you can use a smaller dose of something that has a higher potency and possibly even less frequently, likely less frequently, than using higher doses of something that is less potent, okay? Higher doses and more frequent dosing. So there are reference conversion charts list doses for common medications that can provide equal amounts of analgesia. So there's a table on 11.9, and that just kind of lays out like what options and dosing you have available, okay? So how could you lower somebody's dosing? In practice, when converting from one opioid and/or route to another, equianalgesic tables are frequently used for conversions. The tables are based on numerous studies, expert opinion, so evidence-based practice, but there is no single universally accepted evidence-based equivalency table. So equivalency tables are going to vary by facility, maybe even by pharmacist, right? I suspect pharmacists might have some opinions on this, and your physicians, if your physicians, especially pain specialists, right? Because this is going to be something that they are most familiar with. So as nurses, we're not going to be prescribing, but we may ask, hey, is it an option maybe to use something like a fentanyl patch that lasts for 3 days versus this Q4 morphine? Would that be a possibility for this patient? And you never know, that physician just may not have, thought about that. We're the ones spending the most time with the patients, so we end up asking those types of questions. This talks about demand dosing. So traditionally, pain medications have been administered by nurses either on an ordered frequency schedule or on an as-needed, PRN basis. This approach allows nurses to assess pain and to determine the most effective pain management treatment from a range of pain management options, as well as to monitor for and prevent treatment-induced side effects. In spite of considerable professional education about the science of pain management, studies indicate that nurses routinely underestimate the amount of pain experienced by patients and significantly undertreat pain in a demand dosing pain management model. There have been several theories put forth as to why demand dosing models have led to poorer pain management outcomes. It has been suggested that nurses implicitly substitute their judgment as to how much pain the patient is experiencing over that subjectively reported by the patient. So basically, we are believing our own interpretation of the pain versus what the patient is telling us. And, sometimes this might be beneficial if we think that the patient is undermining or underestimating their pain. But what the studies have suggested is that nurses are the ones underestimating patients' pain, and that then we go and use PRN medications accordingly. So we are underdosing patients because we are underappreciating how much pain those patients are in. So when asked to describe the key assessments and assumptions underlying their pain management decisions, nurses routinely report difficulties in validating subjective patient reports with objective clinical manifestations of pain. Although there are few well-studied or validated objective clinical manifestations of pain, when there are inconsistencies between a subjective report of patient pain and objective data, nurses tend to favor objective data. Nurses, for example, will question a patient's self-report of pain of 10 on a scale of 1 to 10 when they bring pain medication to the bedside of a sleeping patient. I can tell you this is 100% happened, right? You're talking to your patient says they're in pain, they tell you that their pain level is 10, and then you go back in, you go get their meds, maybe you had to get water for somebody else, something else, whatever, a few minutes have passed. You go back in and the patient is asleep. Well, logically, do you feel like a patient who is at a pain level of 10 is going to be able to sleep, right? Doesn't that kind of feel like it goes against what we have been taught? But that is what they're finding is the problem and why patients are being undertreated. This experience then tends to influence subsequent pain assessments, such that nurses can become quite skeptical of patient self-reports if they do not conform to some preset image of what a patient in pain should look like. So again, our person says patient level of 10. Wouldn't you kind of expect them to be sort of grimacing, maybe a little agitated, restless? We may even expect pain level of 10. Heart rate should be up. Blood pressure should be up, right? We should be seeing some things that indicate to us from an objective standpoint that this person is at a level of 10. But what they're finding is that is not necessarily always the case, because again, we go back to that pain experience being subjective, and many factors go into what that pain experience is for that patient. So these studies have said nurses are underestimating because that 10 out of 10 pain guy, he doesn't look like a 10 out of 10 pain guy to us. So, we have to really think about how we think about pain. And how we interpret what is going on with our patients. So rather than being seen as a direction to medicate a patient as needed, it is often interpreted as administrating a medication only on patient request. So this is talking about PRN medications, okay? Nurses may administer pain medication at lower doses or at longer intervals than dosing guidelines suggest because of concerns about the development of respiratory depression or addiction. So sometimes we hold off on giving pain meds as ordered, right? We may wait until a patient requests medication, often means that patients are in more intense pain before receiving an analgesic. So if we are waiting specifically for a patient to request that pain med, they may wait until they get to that 10 out of 10. And then it is a lot harder to back off a 10 out of 10 versus maintaining a 5, right? So we really don't want our patients hitting 10 out of 10 because then it's going to be, an emergency situation. They're going to be sweating, vitals are a mess, the whole thing, and we have to try to get them back to that 5. But what they're talking about is when we wait for patients to request the pain med, a lot of times that pain has escalated. So demand dosing puts authority and control in the hands of providers rather than in the hands of patients. Not only does this lack of control over pain management increased pain anxiety about when their next dose will be or whether they will find pain relief. But this anxiety can also actually exacerbate the pain experienced by patients, right? Because now they have pain, but they're also anxious. When are they going to come with my pain meds? What if they forget, right? Strategies for improving the clinical effectiveness of demand dosing models are outlined in evidence-based practice, maximizing the effectiveness of demand dosing pain management models. So this is in your book. So there is that. So take a look at that, okay? That's a good thing to kind of think about because administering pain meds definitely something we do on a fairly regular basis. Pain-controlled analgesia. So this is your PCA pump, right? Philosophically, PCA puts patients back in charge of their own analgesia. In practice, one of the few places patients can exercise much control over their dosing and scheduling of medication is in the home. And even then, prescriptive limits on how much pain medication may be dispensed and undereducated patients contribute to ineffective self-analgesia for most patients. In acute care settings, PCA is generally used to refer to self-control of medication delivery for the small subset of patients receiving medications via IV or subcutaneous infusions, right? Usually they'll have that pump, okay? Pumps have been designed to be programmable and responsive to interactive patient commands to administer medications. Often these pumps are used first to deliver a bolus dose of medication, usually an opioid, and to provide then a continuous low dose or background dose of analgesia. Patients who are experiencing pain can self-medicate by pressing a control button that delivers a preset additional dose above the background dose. Programming determines the maximum amount of medication that a patient may deliver in a prescribed time frame. If the patient attempts to self-medicate beyond these dose and time limits, the patient is locked out of the system and cannot receive additional doses above the background dose. So it's not that patients can just haphazardly be administering themselves morphine, right? There's parameters on it. The benefits of PCA are well documented. Patients report improved pain relief at lower doses of medication and with fewer side effects than with conventional approaches to pain management. Self-control over pain medication reduces anxiety about when a next dose might be delivered and about having to ask for medication. Patients are able to self-taper doses as their pain lessens and are generally able to discontinue pain medication earlier than with demand dosing models of pain management. One of the challenges of PCA, however, is pain control during extended periods of daytime rest or nighttime sleep. Basal levels of pain medications may be insufficient to provide sustained periods of pain control without waking to redose. Some pumps have more sophisticated programming algorithms that recognize patterns of self-medication and augment patient-delivered doses during periods of inactivity. Frequent patient assessments, which include patient education, ensure that the patient understands how to recognize when they need additional doses and how to access the device. So we need to make sure that the patient knows how frequently they can use the device, how to use the device, and we need to talk to them if they're worried about what to do when they're sleeping, right? Because they may then get anxiety related to that. This is talking about non-pharm, non-invasive options. Nurses have long recognized the critical role of the healing environment in pain management. Bed linens that are clean and smooth at intervals help bedbound patients feel more comfortable. Pillows and positioning devices that are soft and provide ergonomic support can minimize tension on incisions or reduce muscle spasms associated with deeper pain. Ambient light and temperatures, as well as odors and even color choices in the care environment, can stabilize and elevate mood, which can help moderate pain perception. Nurses, however, are challenged to provide a calming and healing environment in most modern healthcare settings, which can be noisy and frenetic with interruptions around the clock. Higher nurse-to-patient ratios or complex task lists often limit extended contact with patients. So this talks about positioning. There is no one best position that promotes pain relief or comfort, right? It's subjective. It's based on what helps the patient feel comfortable. There's also heat and cold application. In a facility situation, we only use hot and cold with an order, okay? Because using inappropriate care of heat and cold can cause skin damage, and you need to be very specific about the temperatures, the time, all of that. So hot and cold therapy in facilities is done with an order. The application of heat and cold is situationally recommended to reduce pain associated with underlying muscle, skeletal, or neurological pathology. Cold is better than heat, for example, at reducing low back pain with spasticity associated with nerve injuries and degenerative joint disease. Most patients, however, prefer heat to manage lower back pain discomfort in the absence of spasm, although neither cold nor heat brings sustained or permanent pain relief. So it's just kind of a temporary fix, but it is effective, right? Another thing we can do is range of motion and exercise. So passive movement of a joint through its normal range of motion is encouraged to prevent joint stiffness, promote motion, and prevent shortening of joints, joint supporting ligaments. Stiff or stiffening joints should be manually manipulated to the point of resistance, but not pain. Patients can also be encouraged to actively move their joints through their normal range of motion. Families can help with this, right? This is definitely something you can show families how to do. There are distraction therapies. Any activity that cognitively refocuses attention to stimuli other than pain can serve as therapeutic distraction. The most effective distractions are those that are interesting to and appropriate for the patient's situation, as well as those that engage the widest range of senses. Large wall murals of nature scenes, for example, coupled with headphone-delivered nature sounds, have been used to distract patients undergoing bronchoscopy and dental procedures, as well as during childbirth. Other techniques that can be used to cognitively refocus or distract patients in pain include many initiated by the patient, such as watching television, reading, doing puzzles or crafts, listening to music, making phone calls, or otherwise engaging in conversation. Nurses also use these same techniques to therapeutically distract patients. Music therapy, for example, is very versatile. This comes down to, when we are doing a procedure on a patient, whether placing an IV or, maybe just cleaning them up, we talk to the patients. We distract the patients from what is going on. And that's distraction therapy. Guided imagery is a technique that therapeutically uses the patient's imagination to create mental pictures or situations that are soothing, relaxing, or pain relieving. Some practitioners describe guided imagery as helping patients to daydream in a very deliberate way, whereas others describe guided imagery as a form of self-hypnosis. Meditation is something else that can be used. Hypnosis, possibly, right? Prayer, spiritual connection helps a lot of people. And don't forget, prayer means different things to different people. And even people who don't describe themselves as religious may consider themselves spiritual, and prayer can be very helpful, right? There we go. Moving on. All right. This talks about non-pharm invasive options, all right? Transcutaneous electrical nerve stimulation. This is a TENS system. This is a non-pharm option. It basically uses electrodes to send electrical nerve impulses or electrical impulses through the nervous system, so it causes nerve stimulation. There we go. So TENS units can be used. You can actually get TENS units for at home. They kind of cause like a tingling, a vibration, whatever. A lot of people like those. There's also deep brain stimulation. This is used as treatment for intractable pain. It's been used for like 50 years, so it's been around a while. It can be effective, right? So what they do is they go in and they basically put a probe into the brain, and then they use electrical signals to generate a pulse, right? and then it stimulates the brain, stimulates the central nervous system, and it can help with pain relief. So what they're using it now with, which is super interesting, is relief of tremors related to Parkinson's disease. And I think deep brain stimulation is going to be one of those things that continues to grow as we realize all the things that it can be used for. Older adults, this is our consideration for older adults with pain. Pain is a common experience for older adults, right? And so it's often viewed as like inevitable. It can be easily dismissed because we're like, you're 88, of course you're in pain, right? But pain is not considered a normal part of aging. Okay, and there's things that we can do to educate people to help reduce their pain regardless of age. One of the things, though, is older people may have fear of addiction, over sedation, misunderstanding of mixed pain conditions, right? They may have other things going on, or lots of things going on all at the same time, all with its own pain aspect. So there's a lot of education that goes into helping older adults with their pain management. Also, we may be talking about having cognitive or communication delays. This could be older adults, maybe with Alzheimer's or dementia, but also it could be younger cognitively delayed patients, right? And so with that, we need to take into consideration, who knows them best and what signs or symptoms can we look for that indicate pain. There's pain scales out there that are specifically geared towards patients who cannot respond, using like a 1 to 10 or even the Wong-Baker faces. There's one called the FLAC scale that hospice uses, but let's see, I think there's 6 different areas that the FLAC scale looks at. So it talks about grimacing, it talks about facial expression, it talks about baseline, all of that stuff. So it takes into consideration other things that will help us identify pain. Let's see. So I'm just looking through here, seeing if there's anything else we need to talk about. No, that is good. All right. So all those speaker notes are on there. Really, the biggest thing is just knowing, being aware of not underestimating pain in these groups of people, right? And that there are tools out there and considerations that we can work with to identify pain and make sure that they're not in pain. This is evidence-based practice of patients for self-management of acute and chronic pain. This is straight out of the book. This is slide 26. Take a look at that. This is complementary and alternative care initiatives. When we say conventional medicine, that's Western medicine, right? When we say conventional, and that is the dominant healthcare system in the United States, Canada, and most of Europe. So conventional medicine is a well-established, organized system that is rooted in scientifically proven theories. It is practiced by licensed providers, including physicians, nurses, physical therapists, OTs, social workers, and other allied healthcare professionals. When we say allied healthcare professionals, that just means healthcare professionals who aren't doctors. Complementary and alternative medication, this is known as CAM, is a collection of diverse traditions and healthcare practices that have been handed down through the generations. The therapies and products that are recognized as CAM are rooted in ancient wisdom tradition, folklore, cultural traditions, and religious and spiritual practices. These traditional practices and doctrines are based on theoretical foundations. The CAM model for delivery of care has 3 guiding principles. The goals of CAM include the promotion of wellness, the prevention of illness, a reduction in treatment side effects, improvement of the immune system, and enhancement of quality of life. Although these goals of care are not unlike those of conventional medicine, CAM healthcare practices are considered outside the sphere of conventional scientific methodologies. Hence the terms alternative and unconventional as an approach to medical treatments. So, like we talked about in class, this is when your Nana is like, drink 3 peppers mixed with honey and your stomach ache will go away. Nobody knows why it works. It just works, so you do it, right? So not a whole lot of scientific backing, but what's funny about a lot of these CAM practices is that as they're researched, the science is being discovered. So there is scientific backing. It's just not what we go with in the first place. It's just not what we know about. This is straight out of the book. This is box 12.1, slide 28. This is just the guiding principles of complementary and alternative medication. So this just talks about those 3 aspects that the previous slide referenced. So take a look at this if you are not familiar. The National Center for Complementary and Integrative Health, they are kind of like a guiding force of CAM options. Today, the NCCIH advocates for complementary health approaches through scientific, evidence-based research projects and provides a clearinghouse for safe and reliable information related to these modalities. So the NCCIH kind of gives us a scientific backing, an organization where we can go to find out more about these CAM options, right? If we want to know if they're safe for somebody, if it's something we might recommend, or talk to a physician about. Ayurvedic medicine, I am positive I am saying that wrong, is a 5,000-year-old integrated natural medical system that originated in India. It uses a combination of herbs, yoga, massage, and diet to restore balance and wellness. The belief behind this treatment method is that there is an interconnection between the mind and the body. You know, and we see that in a lot with CAM options, right? That's kind of the whole concept of it. The distinctive connection, when encouraged, will facilitate, maintain, and restore health and well-being. It includes physical, mental, and spiritual practice to maintain inner harmony. The individual is evaluated based on their unique, well-defined energy called doshas. According to the pattern of the doshas, various modalities are incorporated into a complex change in lifestyle. There's also traditional Chinese medicine. This uses acupuncture and herbs, right? This medical system, also referred to as acupuncture, is the oldest and most continuously practiced medicine in the world. The goal of treatment is to sustain the balance or flow of qi. Probably saying that wrong as well. Qi is defined as the universal life force or personal life force and is considered the connecting energy that influences all living and non-living things. The flow is facilitated by the acupuncture's point placement of small needles, which are inserted just under the surface of the skin. So acupuncture will be used, people really love acupuncture, and it's a great option for pain relief. And definitely something you may hear physicians recommend, because you can go, it's painful, it's invasive obviously because they're putting the needles right into specific areas, but overall, you know, it helps more than it hinders. Naturopathy, brought to the US from Germany in the 1800s, but some of its practices are hundreds of years old, including natural therapeutics such as acupuncture. So the Germans were using acupuncture as well. Hydrotherapy, manipulative therapy, homeopathy, and botanicals. The focus of care is on supporting health, not combating illness. So they're trying to keep you healthy from the get-go, right? So that you don't have to deal with illness. Naturopathic providers integrate care according to the individual needs of the patient. We have Native American medicine, right? We're probably, being in Arizona, we're familiar with Native American medicine, or should be. is a collection of diverse indigenous customs, beliefs, and practices. It is believed that humans, community, and nature are interconnected and that healing must be restored to a state of wholeness to achieve optimal spiritual balance, well-being, and harmony. Native American healing traditions include shamanism, which represents a spiritual practice between the physical land, spiritual worlds, herbal medicines defined by common practices such as the use of tinctures, salves, and teas, and ceremonial healing practices such as chanting, dancing, and singing to ask for spiritual help and guidance. So if we are in a facility and somebody brings in a tincture, salve, or tea, our main concern is what is in that, right? We just need to know what's in it. Sometimes facilities, like if you are in a long-term facility, they may let you use something like that. In an acute care setting, pharmacy is going to need a full-on list of everything that is in that tincture, salve, and or tea. And then it's going to be kind of up to the physician whether or not they allow that use. So, but you're going to see that, right? People are going to bring stuff in. So, and as nurses, that's just what we need to think about. Here's a little slide safety alert related to acupuncture. This is slide 31. This is straight out of your book. So take a look at this, like when we need to consider not using acupuncture, right? When it is contraindicated. This is just about another CAM continued. So really it's about mind-body therapies, right? There's energy healing, there's dietary supplements, any dietary supplement that we talk about, like with the teas and creams and tinctures and salves and all of that, we just need to know what's in it. What are you really taking? Some physicians will be all for it. Some physicians will be like, no, let's hold off on that. This could interact with your other medications. So we really, in a facility setting, we just want to know what the person's taking, what those interactions are. Conversations you'll have, people will bring stuff in. Family members will bring stuff in and give stuff to patients without your knowledge. So it's not bad to just kind of verify what your person is taking. If the family, if they normally take vitamins, just verify with the family, like, did you bring those with you? Can I see the bottle? Can I give those to pharmacy? Let's not take any of those without consulting the physician first, just to make sure that it's not going to interact with anything that the physician has the patient on. Because a lot of times, obviously, a patient's in a hospital, they're going to be on new medications. So the family may not even be fully aware of all the stuff that the patient is on and what interactions could occur. Nursing implications related to CAM, definitely CAM is growing in popularity. So we always need to be thinking about it. And then we need to also kind of be aware of its usefulness, safety, and appropriateness related to patient care. So we may be asked, what do you think about that? Do you think it's helpful? And it's okay, as long as we're educated on the subject, to give our opinion. And it's okay to say, you know what, I don't really know anybody who's used that. I don't really know. I'm probably the wrong person to ask about that, right? According to our book, about 40% of adults use some form of CAM. So that's a whole bunch of people. So most often adults choose CAM for its natural characteristics and the quality of care that they receive. Individuals are seeking a value-driven partnership and rapport related to overall healthcare needs. So they like the interaction that they're finding from CAM providers, right? It tends to be more of a holistic approach. And honestly, it tends to be more of a nursing approach versus a physician approach, because we want to know, patient advocates. We're patient advocates. So we're a CAM supporter or CAM provider has a much more patient-centered approach to dealing with care. Let's see. This also talks about there's a lot of opportunity for nurses to develop evidence-based practice research related to CAM. As it becomes more popular, we need more research backing for it, and that's a really good topic for nurses to look into. This is box 12.3, slide 34. This is just the most common complementary and alternative medicine modalities used by adults. So just take a quick look at that. This is box 12.4. This is questions to ask when seeking a CAM provider. So this is stuff that we could educate patients. You know, if you're interested in CAM and you're looking for a provider of CAM, these are things to ask him. So as nurses, we should have these questions in mind because this is definitely an education opportunity and an opportunity for us to support patients if they're interested in using CAM. All right, now we are moving to connective tissue disorders. So first one up is osteoarthritis. Yay. Osteoarthritis involves weight-bearing joints, such as the knees, hips, feet, and lumbar spine, but it can also affect cervical spine, proximal interphalangeal joints, and distal interphalangeal joints of the hands. Osteoarthritis involvement of the shoulders and elbows can occur after trauma, inflammation, or overuse. So all the joints, basically. There are multiple risk factors associated with osteoarthritis, including age, especially individuals over 50, females, people who are obese, occupations that involve repetitive motions, sports activities, previous injury, muscle weakness, genetics, history of inflammatory arthritis, and or other bone and joint disorders. Aging is one of the most prevalent risk factors for developing osteoarthritis. Only 0.1% of people ages 25 to 34 are affected with osteoarthritis versus 80% of individuals over 55, right? Ow. However, osteoarthritis not considered a normal process of aging, okay? So although it's super common, not considered normal process. Osteoarthritis is a disease that affects the joint as a whole because of biological, chemical, and viscoelastic changes within the joint. So, right, our joint is moving and it needs to be elastic and flexible. Well, what happens is that changes and it becomes less elastic, just like everything else, stiffens up on you, right? So it becomes less elastic, it doesn't move as well. There's chemical changes that can cause pain, and then there's biological, the joint can degrade, right? You can have bone degradation, the bursa in between can degrade, can inflame and all of that and cause pain. So all sorts of things. Clinical manifestation of osteoarthritis includes, hold on, I went too far. Progressive pain that increases with joint use. So the more you use it, right, the more that joint is going to hurt. Decreased range of motion, so you can't do all the things you used to do. Tenderness to touch over the joint line or around the joint. Swelling, soft tissue swelling, deformity, and instability. You can also get crepitus, which is kind of like this crackling, popping, grating sound or feeling due to air or gas under the skin. So that may also be present. Diagnosis can be made on clinical manifestations without lab testing or x-rays when the patient is 45 or older and presents with persistent usage-related pain in several joints and morning stiffness that lasts less than 30 minutes. So basically, they don't have to do labs or x-rays. If you're over 45 and you are describing what sounds like osteoarthritis, guess what? You have osteoarthritis. So don't forget that morning stiffness that lasts less than, sorry, I'm steering you wrong. Morning stiffness that lasts less than 30 minutes, okay? Treatment, we can use meds and non-meds. There's really no therapy available to stop the progression of osteoarthritis. Goals of care include decreasing pain and improving or maintaining joint mobility while avoiding the toxic effects of pharmacological therapy. So anything, whether you're taking NSAIDs, aspirin, acetaminophen, whatever, if you are overdoing your doses or taking it frequently, obviously there's side effects related to that we need to be aware of. So non-pharm therapies might be weight loss if indicated. We may use our heat and cold. Keep in mind, cold we think of for joints primarily, and heat we use with muscles because heat opens up all those blood vessels and brings more blood to the system, which helps loosen things back up. Cold, all the cold is doing is helping with inflammation. It's not going to increase flexibility. Heat will help increase flexibility because of the increased blood flow to the area. People may also want to try aerobic exercise, physical therapy. This can be range of motion and muscle strengthening. People may have to use ambulatory assistive devices, especially like if you have a knee injury and that knee every once in a while goes out on you, right? You may want to have a cane or some sort of walker just for stability, so that, because if that knee goes out, your risk is to fall, which can be a whole other thing, right? Whole other damage can occur related to a fall. You want to make sure you're wearing the appropriate footwear. If you have a knee that is going out on you every once in a while, do not wear your stilettos. That is not appropriate footwear for that situation, right? You want to stick to something flat, enclosed, something that's going to stay on your foot, maybe not flip-flops. They may also do occupational therapy. There's joint protection, braces and stuff people can use. And then conserve energy, right? If you're in a lot of pain or it's hard to go walking out and about, plan your day accordingly. Pharmacological therapy, we have acetaminophen for mild to moderate pain. You can have NSAIDs also. They can do injections of steroids and hyalurons. These kind of help when you have lost all the fluid in between your joints. The hyalurons can go in there and they offer lubrication, so that if you have a bone-on-bone situation, well, at that point it's too late. But the hyalurons can kind of help whatever lubrication you have left, right? And those can be helpful for a while. Let's see what else we have here. You can, all of those med therapies you can use together, so they can be used. You can use NSAIDs, you can go and get hyaluron injections, you can get steroid injections. You just have to be aware of potential side effects of all of that stuff. This is a picture of osteoarthritis in the hands. You are going to want to know these. Herbert's nodes are the most distal joint of the fingers, and then Bouchard's nodes occur on the middle joint, all right? So you get that joint swelling, deformity, pain, all of that. I always remember it like if we're moving from proximal to distal, right? Bouchard's comes first, B comes first in the alphabet, and then H, Herbert's. So Bouchard's is the middle joint, and then as I move distally out on the finger, Herbert's is the next one. So B is first, and then H. This is an NSAID safety warning. This, of course, we've talked about before. So it's slide, let's see, I don't have glasses on, slide 38. This is straight out of the book, but take a look at this, just our NSAID warning, and contraindications and signs and symptoms that we're going to want to look for when we may need to stop our NSAIDs. This is geriatric considerations for NSAIDs. Take a look at this slide. This is slide 39. This slide, slide 40, just points to areas where you can have osteoarthritis. Osteoarthritis can be unilateral. So, we talked about it being exercise induced. It can be exercise induced. So if you're a runner, you may have one knee that has osteoarthritis, right? It's not necessarily both knees. If you're a weightlifter, like you could have a knee and an elbow. you know, on opposite sides, right? Left knee, right elbow. So osteoarthritis can be unilateral. This slide just points out all the points where you can have osteoarthritis. So that's great. It's everywhere. This talks about nursing considerations, assessment. We'll start with assessment, vital signs. You can have hypertension related to chronic NSAID therapy. So that's a consideration. NSAIDs can also alter renal function. So we want to be looking at that. And because they can alter renal function and reduce sodium excretion, so the perfect. So the body is holding on to more salt than it should. With that, you can have enhanced fluid retention because salt and fluids like to hang out together. So if the kidneys aren't working right and not getting rid of all your sodium, you're going to have extra water. So you may see some possibly edema, puffiness, that sort of thing. We just talked about weight. You know, weight is the greatest indicator of fluid issues, right? Not necessarily renal insufficiency, but fluid issues, right? So we're going to be looking at a person's weight when they are using NSAIDs a lot related to potential for renal insufficiency. Skin integrity, we're going to think about that. You know, maybe they have decreased physical mobility because it hurts. Maybe they used to be a runner and now they just sit on the couch because their knee is garbage, right? So now we have decreased physical mobility, and that, of course, like we always talk about, can lead to skin breakdown. Serum creatinine, so creatinine levels in the blood, can be affected by NSAIDs, so there's labs that we look at. Actions we're going to talk about analgesics and anti-inflammatories with appropriate education. We're going to possibly talk about the use of opioids, right? This could be an acute pain situation. Maybe osteoarthritis doesn't always end in surgery, you know, with a joint replacement, but it is a possibility. So if somebody goes in for surgery, we're definitely going to be talking about opioids because that is considered an acute pain, and opioids are a pain treatment that we would be using. We would use cold packs for painful joints. That helps reduce inflammation. Heat pads for the muscles. That helps relax the muscles. Teaching is going to be related to all those meds, the NSAIDs, the Tylenol, all of that. Maybe aspirin. Your person may be using aspirin, which can lead to bleeding. Let's see. We may want to talk about going to occupational or physical therapy, right? They may feel like they're too much in pain to continue exercising, but going to PT might help them have better control of that situation and keep them moving, keep them mobile. They may need braces, so we may have to help them with that. They may need home health care, right? So we would educate them related to what to expect from home health care. Maybe even like what questions to ask and what needs to be available in the home and all sorts of stuff like that. We would also talk about safety hazards. If you have a knee that's constantly going out, then we talk about things, you know, clutter. What's your bathroom look like? Does your bathroom have a handle? If you fall suddenly, is there somewhere for you to grab onto? All those safety things. All right, now we're moving on to rheumatoid arthritis. So rheumatoid arthritis is considered autoimmune. Osteoarthritis is not an autoimmune condition, okay? It's just a breakdown of the joints. Exact etiology of RA is unclear. However, it is well understood that genetics and environmental factors play a key role in the development of the disease. You know, when we talk autoimmune stuff, there's always a genetic predisposition and then there's a trigger, right? So like any autoimmune thing, we have genetics and environmental factors. First degree relatives of patients with RA are at a 1.5-fold higher risk than general population of developing RA. Environmental factors such as cigarette smoke, bacteria, and viruses have been implicated as initiating factors for the development of RA in the genetically predisposed population. Some patients initially diagnosed with RA may experience long-term remission within 1 year of onset. So it could go away. You may have RA signs and symptoms, and then you go into a remission period and you don't have it anymore. If you don't enter a remission period, about 60% of that patient population will be disabled within 10 years. The nodes and the swelling that occur related to RA is incredibly debilitating, not to even to mention the pain, right? RA is a chronic systemic autoimmune inflammatory disease characterized by an inflammatory process that affects freely moving joints, causing pain and swelling. The involved joints are usually distributed in a symmetrical fashion. So this is going to be bilateral, right? Our osteoarthritis was unilateral. Our RA is bilateral. So if you have it in your left wrist, you're going to have it in your right wrist. Rheumatoid arthritis primarily targets the synovial membrane. So the synovial membrane, that is what provides that fluid in between the joints that helps keep everything moving and lubricated, right? Clinical manifestations, so signs and symptoms of RA, should be suspected in adults with inflammatory polyarthritis. So arthritis in more than one joint. Bilateral, first of all, and then in multiple joints. Clinical manifestations include joint pain, joint swelling, morning stiffness, and fatigue. Onset is often insidious, with vague complaints of joint and muscle pain that evolves into joint pain with synovitis. So that synovial fluid, you're going to get inflammation in between the joints, okay? This can lead to joint destruction and deformity. Rheumatoid arthritis, if left untreated or inadequately treated, leads to irreversible joint damage and disability. Common joint deformities include swan neck deformity caused by hyperextension of the proximal interphalangeal joints, boutonniere deformity caused by abnormal flexion of the proximal interphalangeal joints, and ulnar deviation caused by the lateral deviation of the phalanges. So if you have ever seen a picture of people with RA, their hands are just bent. It's so sad. And it's both hands because, again, it's bilateral, right? So it's not like with osteoarthritis, you know, I'm going to end up with like TikTok thumb eventually from scrolling, but at least my left hand will be fine. So when evaluating clinical manifestations, patients typically present with peripheral joint pain, which is usually symmetrical, and complain of morning stiffness lasting greater than 3 minutes. So with our rheumatoid arthritis, that morning stiffness lasts greater than 3 minutes. 3 minutes, 30 minutes, if only greater than 3 minutes, which is really not a lie, but greater than 30 minutes. With osteoarthritis, it's less than 30 minutes. So with osteoarthritis, what happens is you get up, you start moving around, and that stiffness feels better. One of the biggest things they recommend for osteoarthritis is like taking a warm shower, because that gets all that blood flow going and loosens up those muscles, right? So, but with RA, it's morning stiffness lasting greater than 30 minutes. Symptoms are obviously going to persist for greater than 6 weeks. That's going to help differentiate it from OA initially. Another important finding with the RA is that synovitis. Tenderness and synovitis are assessed by palpating each joint individually. Tenderness is subjective, whereas synovitis is objective. It's an inflammation, so we're going to be able to see it, right? The clinician is usually able to detect the synovitis on examination via palpation, or if not detected by palpation, they can use ultrasound. Diagnosis, so RA is diagnosed by clinical manifestation, lab values, x-rays, and/or ultrasound. Treatment, non-pharm. Education is very important in the management of RA. Patients must understand their disease and the measures they can take to help manage the disease. Range of motion exercises promote joint mobility, reduce stiffness, and improve muscle strength. Aerobic exercise promotes cardiac health. Physical and OT may be necessary to teach patients appropriate exercises and how to protect their joints. Evaluate the need for assistive devices and teach proper use of devices. We want proper nutrition. We want to prevent obesity, and we want to decrease our risk of heart disease. It is important for patients to take rest periods to manage fatigue and joint pain. Pharmacy, so pharmacological meds. So the goal of pharm treatment is to control the inflammation that leads to joint and tissue destruction, decreasing joint pain, synovitis, and stiffness, as well as maintaining joint function and preventing joint destruction. Treatment decisions are based on disease severity and response to medications. Initial treatments include analgesics, NSAIDs, and glucocorticosteroids. Analgesics include Tylenol and narcotic agents. Let's see, we may use anti-inflammatories, steroids. Steroids work on inflammation. They can be given by IV too. They can be given IM or IV, and they can be used more locally to focus in on where the pain actually is. And we also, the one thing that we're going to see with RA that we don't see with OA being used is DMARDs. So these are disease-modifying anti-rheumatic drugs, okay? So DMARDs are going to be used with RA. So this slide is about DMARDs. So we have synthetic DMARDs. These include, but are not limited to, methotrexate. Methotrexate is really the one we're going to hear the most about. Hydrochloroquine or Plaquenil, that is used in lupus. They had also kind of used that during COVID. So it's kind of interesting. So methotrexate and Plaquenil are probably the ones you're going to hear the most about. Each of these, what's interesting with the DMARDs is each of them alter the immune system in various ways. So, you know, the immune system, it's a cascade, right? So the DMARDs affect the inflammatory response along the cascade in different areas of the cascade related to inflammation. So you can use one DMARD, or if that single DMARD is not working, you can use a few DMARDs, right? Because they affect the inflammation cascade in different areas. So it's kind of nice that you can use them all together. Let's see. Many patients respond well to methotrexate, which has been accepted as a first-line DMARD of choice to treat RA. Methotrexate is taken once weekly orally, subcutaneously, or by IM. There is a safety alert related to methotrexate that we will look at. Traditionally, patients move on to additional or alternative medications if methotrexate alone does not control the disease. There are also biologics available. So over the last decade, several medications known as biological therapies, which are genetically engineered medications made from living organisms and their products, such as proteins, have obtained approval by the U.S. Food and Drug Administration to treat RA. These medications have proven to be beneficial in slowing or even halting the progression of RA. I mean, and that's one of the biggest things with RA is that it's progressive, right? So usually, you know, what was that? 60% of people within 10 years will be deformed. I mean, so anything that could slow the progression of RA, that's huge. That's a definite win. So biological therapies target specific entities of the inflammatory cascade, thus interrupting the immune response and decreasing inflammation. So they work a lot like the DMARDs, okay? They work on that inflammation cascade. This talks about non-biological DMARDs. Again, methotrexate talks about our nursing implications. This is slide 44. This is out of the book. Definitely take a look at this. Be familiar with methotrexate, okay? Here is a safety warning from methotrexate. We worry about liver toxicity, hepatotoxicity, liver toxicity with methotrexate. So one of the things is you want to avoid alcohol. And don't forget, when we tell patients related to, in particular, medications, like you need to avoid alcohol, I don't mean that you get to have a half a glass of whatever at dinner. No, avoid means none, right? Not just reduce, but avoid. Let's see, and it talks about patients with renal insufficiency. They may need to use lower doses of methotrexate. So again, this is slide 45. This is the safety alert related to methotrexate. You're going to want to take a look at that. This is just a picture of the swan neck deformity, the boutonniere deformity, and the ulnar deviation. Now keep in mind, like, you can have all three deformities on one finger. And just think about how painful that's got to be. So take a look at that. This is table 20.2, slide 47. This compares osteoarthritis to rheumatoid arthritis. Definitely become familiar with this table, okay? Rheumatoid arthritis RN considerations. So vitals wise, like our vitals may be altered related to pain, but really we're going to be looking at joint pain and mobility. We're going to be looking at disease progression. Don't forget that an increase in temperature can indicate infection, which is never good. We would want to treat that. Lab testing, for the most part, we're just going to be looking at that CRP and ESR. Remember, CRP is C-reactive protein, and ESR is erythrocyte sedimentation rate. Both of those just indicate an inflammatory process. They don't tell us what inflammatory process, they're non-specific, but they do tell us that an inflammatory process is in play in the body. We're going to want to look at hemoglobin. Hemoglobin in patients with RA can actually be lower than normal. So we're going to want to pay attention to that. But also, if they've been taking a lot of aspirin or NSAIDs just to treat this pain, you could potentially have a GI bleed going on as well. So we're going to want to take a look at our hemoglobin. Serum albumin, so albumin levels in the blood, platelet counts, liver and renal function. Don't forget, liver is ALT and AST, and then renal, our kidneys, is BUN and creatinine. Our actions are going to be to administer meds as ordered, right? Including analgesics. They may be taking steroids, they may be on DMARDs, all sorts of stuff. Teaching is really going to be related to those meds. When do they take them? What can they combine them with? Reporting signs and symptoms of infection early. These medications, if they are interrupting the inflammatory system, the inflammation system is the first thing that's going to respond when the body thinks we might have something like an infection going on. So if we are interrupting the inflammatory system, we are interrupting the body's natural response to infection. So these people could have an infection and the body's not going to be able to fight it. So anytime we are talking autoimmune diseases, people are going to be on medications that kind of tamps down the natural response of the immune response. Well, that puts them at risk for infection because the body's not going to respond appropriately. So we need to make sure that they are aware of not only signs and symptoms of infection, but how to avoid infection. So if you can avoid large crowds indoors, maybe stay away from that, right? Maybe wear a mask if you are going to be in close contact with people. An N95 is your best bet, but surgical mask will at least keep out the big fat saliva, droplets that fly around. During respiratory season, don't hang around with a lot of little kids. They are petri dishes, okay? So, all sorts of teaching related to that. They are also going to want to see a rheumatologist on a regular basis, not just when they have flares or when something changes, but on a regular basis. Um, Keep current with vaccinations. That plays into the immunocompromised aspect, right? Make sure you're up to date. And then physical and OT therapies can help preserve joint function, which is really what we're aiming for. Now we're moving on to scleroderma. Scleroderma is just a weirdo disease. It primarily affects the skin, but can involve internal organs. It's autoimmune. Exact cause is unknown. Um, it has external triggers, of course. What happens basically is the accumulation of collagen related to an autoimmune reaction causes tissue damage. And then the cells, the mononuclear cells, kind of cluster together and they cause stiffening, hardening areas of the skin. Now, this would be one thing, but the problem is it can go below skin level. So it's not just external, it can be blood vessels, organs, tissues. So imagine, our organs, think about our heart. Our heart pumps. It needs to be flexible. It needs to be able to move. If our heart is suddenly attacked by an autoimmune disease like scleroderma, where it causes hardening, our heart's not going to function properly, right? Our kidneys aren't going to function properly. Liver's not functioning properly. It can cause major damage. So it causes these fibrotic changes with loss of elasticity and movement. And again, it happens on the skin. Primarily, you're going to see it on the skin, which is kind of one thing. But when you start talking internal structures, it's a big problem. Incidence is related to females more than males. Black individuals tend to develop the disease earlier in life and are likely to have more diffuse disease with a worse prognosis. So diffuse disease, instead of just being on the skin, it's going to attack those internal structures. Scleroderma is not considered a hereditary disease, but patients who have a first-degree relative with scleroderma are more susceptible to developing the disease than general population. It has also been suggested that as in other autoimmune connective tissue diseases, environmental exposures such as infectious agents and occupational toxins may play a role in triggering the disease. So again, genetic predisposition and then some sort of trigger. Scleroderma for signs and symptoms, divided into two main categories, localized and systemic. Localized scleroderma is what leads to those isolated patches of hardened skin. You can also have linear scleroderma, which is lines of thickened skin that affects the tissues, and then scleroderma in coupe de sabre. I don't know what that means, and I'm sure I'm saying it wrong. This is thickened skin on the head. So these three occur localized. So we have the tissues, we have the skin, and then we have the head. And these will occur individually, okay? Localized scleroderma typically does not affect internal organs. So then systemic sclerosis is divided into categories of diffuse and limited. So at that point, what organs are involved? How deep does the involvement go? How many organs, right? And all of that. So diagnosis of scleroderma is supported by clinical manifestations, serum autoantibodies. So don't forget, with these autoimmune disorders, we expect to have autoantibodies to the disease, and we can find those in the blood, right? And there's markers and all these things that we can look at. X-rays can reveal subcutaneous calcification. They may do pulmonary function testing to see if the lungs are involved. They may do all sorts of stuff. They can do a right heart cath just to see if you have any lung disease or pulmonary hypertension going on. Kidney biopsies, possibly. Treatment, no single treatment to manage scleroderma. Treatment is focused on specific organ involvement and clinical manifestations. Systemic steroids, such as prednisone, because steroids work against inflammation, so those can be helpful. Immunosuppressants, we may use methotrexate related to scleroderma. Methotrexate you're going to see used with a lot of autoimmune disorders, okay? It's not just limited to RA. Antihistamines, believe it or not, may help with, because pruritus, so itching, is a thing. So they may use something like an allergy med, an antihistamine. Topicals, moisturizers, vasodilators can be helpful. So there's all sorts of stuff. RN considerations, because we have stiffening of these things, it can affect our vitals, right? So blood pressure could be elevated, heart rate, rhythm, respiratory rate, all of this stuff. And those can indicate that we have deeper systemic involvement. We're going to want to listen to the lungs because it can affect the lungs. So we want to make sure that those sound okay. We're going to want to do a full skin assessment. Musculoskeletal system, because it can cause swelling of the hands and joints, muscle pain, all of that stuff. GI, we're going to want to make sure we auscultate bowel sounds, see what's going on, ask about constipation, diarrhea. With the kidneys, we're going to look at the creatinine levels and BUN. Let's see, liver, ALT, AST. Our actions, we're going to administer meds as ordered, right? We're going to do range of motion exercises with our person. We are going to help them with any referrals they may need related to other organ involvement. They may need to go to a pulmonologist or nephrology, right? If the kidneys are involved. And they may need counseling. Like, this is a pretty scary disease, right? Does not have a good prognosis. So they may need to go to counseling. They may suffer from depression, and we need to kind of help them out with that if we can. Teaching, we're going to talk about disease process. It is a weirdo, complicated disease, and it varies from one patient to another. So you can't even offer them like an expected progression, because it just depends on the patient, and that in itself is hard to deal with because there's really no definitive answer. Same with the treatment. Treatment is based on person to person. So, all of these things are based on how they respond, how it goes, how they're feeling. So, and that can be hard for people, hard for patients, because a definitive answer is much easier to work with, right? So again, you get into that socio-psycho need for support. And then we're going to want to talk to them about protecting skin from trauma. We don't want to risk infection. They tend to have a prolonged healing time because of decreased tissue perfusion. So you want to keep the skin nice and safe. This is just a picture of scleroderma. It shows those darkened areas. That's where the skin has hardened. So imagine that happening to your organs, right? And tissues and all of that inside. All right, now we are talking about lupus. Lupus is another autoimmune. So lupus is a chronic inflammatory disease that can affect virtually any organ system. Lupus is another weirdo one that is very, very individually patient-based. The exact etiology is unknown, as is the case with other autoimmune diseases, but the disease is triggered by multiple factors. Factors include pregnancy, exposure to sunlight, illness, major surgery, silica dust, and medication allergies. Most clinical manifestations of lupus are attributed to antibodies and the creation of immune complexes that are deposited into tissues. So the immune system is overreacting, and the pain and inflammation related to lupus is caused by these autoantibodies and the overreaction of the inflammatory system. Incidence, females during childbearing years are most at risk, African American women are 4 times more likely than other women. What's interesting is Black women, like internationally, not at that same increased risk. It is literally African American women 4 times more likely. So that's just sort of a weirdo, interesting thing, right? It'd be cool for them to figure out what that is about. Clinical manifestations of lupus, very diverse, very vague. They don't follow a clinical pattern. They vary completely from one person to another. There's definitely, though, fatigue. You can have a fever, myalgia, muscle pain, weight changes. Symptoms, all the symptoms are not always present in every person. And with lupus, like you get flares with lupus, and your flares can actually differ. So just because you had muscle pain, like excruciating muscle pain during one flare, that may not be present in your next flare. Clinical course of lupus usually involves periods of remission and then acute disease flares. Diagnosis. Let's see. So the Systemic Lupus International Collaborating Clinic revised and validated the classification criteria to aid in diagnosis. So this organization identified 17 broad criteria that align with the clinical manifestations with specific definitions, some clinical and some immunological. The clinical criteria include skin rashes, such as the lupus malar rash. That's that butterfly rash. That is like a very telltale sign of lupus, but you can also see it with other autoimmune diseases. You may have oral ulcers, thinning hair, joint tenderness, pleural or pericardial effusions, renal and neurological disorders, hematological disorders such as thrombocytopenia, leukopenia or anemia, immunological criteria, positive for ANA, low complement, positive anti-SM, anti-phospholipid antibodies, and positive anti-double-stranded DNA. 4 of the 17 criteria must be present to support a diagnosis of lupus, and at least 1 clinical and 1 immunological. So from that list there, basically they look at the list and go, okay, you have this and you have this. One needs at least 1, you need 4 altogether. 1 needs to be a physical manifestation and 1 needs to be related to a blood draw finding. So in clinical practice, however, patients may not have 4 criteria present to be diagnosed if there is sufficient evidence otherwise. So that's just saying they may go ahead and call it lupus if they think it's lupus, right? This talks about the labs. So positives for autoantibodies, those are known as ANAs. Autoantibodies, don't forget, are antibodies the body produces against itself, okay? With any autoimmune disease, we're going to have autoantibodies. In a urine analysis, we may look at proteins, creatinine, serum creatinine, BUN, again with the CRP and ESR for inflammation. They may use x-rays to rule out other stuff, right? Other causes for pain. Non-pharmacological treatment, kind of all the stuff we've been talking about, right? Like proper nutrition, rest periods, all of that sort of thing. The other thing that gets thrown in with lupus is avoiding prolonged sun exposure. UV can actually cause a flare. So one of the big teaching that we would do, especially if you're living in Arizona, is all those sun things we've learned about, right? Like don't go out between 10 and 4 when the sun is is highest. You're going to want to use the sunscreen. With lupus, they actually recommend an SPF of 50 or higher, and to use that on a daily basis, okay? Regular exercise, range of motion, all that sort of stuff. We're going to use all the things we've been talking about, right? NSAIDs, acetaminophen, steroids, all of that. We also throw in Plaquenil. Now, Plaquenil was on the list of DMARDs, right? Hydrochloroquine. It is actually considered, or it is, an anti-malarial medication. But it has been found to be very helpful with these autoimmune diseases. So Plaquenil is used a lot. Hydrochloroquine, let's see. It talks about just sort of mitigating the effects of hydrochloroquine. One of the ones I know about the most is feeling nauseous. Usually that goes away, but you can put people on Zofran to help with that. We talked about NSAIDs, steroids, biologics. You can also use biologics. And one of the things you just want to encourage people, and this is true for any of these autoimmune, or if you have a chronic disease, whatever your chronic disease process is, carry a list of your meds on you. It's super easy to forget what you're taking, especially if you also do supplements. So just always have a list of meds on you. This is a safety alert related to common lupus medication Plaquenil. This is slide 53. Also, the NSAID alert is on here. Safety alert related to allergies and antibiotics. Yeah, most people with lupus are allergic to sulfa antibiotics. One of those, it's this trimethoprim sulmaltazide, but that's Bactrim. Bactrim is used a lot with skin stuff. It is like a go-to for MRSA, soft tissue things. Bactrim's a favorite, but it is a sulfa drug. It's a sulfa antibiotic. So people not only need to know, like, hey, I'm allergic to sulfa antibiotics, but they should probably be aware that Bactrim, which is what people mostly say when they're talking about Bactrim, not trimethoprim, sulfamethasone, whatever, right? Just be aware of common sulfa antibiotics. With our RN considerations, our vital signs, hypertension could be elevated. Lupus people can have renal or cardiac complications, so you may see hypertension. Let's see. We just want to do our head to toe, past health history, ask them about rashes, all of that sort of stuff. Don't forget about that malar butterfly rash, right? It goes across the cheeks and the nose. Ulcers, oral or nasal ulcers are positive, so we want to ask about that. Alopecia, which is loss of hair. There may be musculoskeletal complaints, joint swelling, anything that they notice. We're going to monitor a bunch of labs, normal labs, BUN, kidneys, liver, coag studies, all the things. CRP, ESR for inflammation. Actions, we're going to administer meds as ordered, of course. You're going to be ordering meds related to specific clinical manifestations, right? Because sometimes our person may have joint pain, maybe they don't. So we're going to have to tailor our actions specific to that patient. And don't just assume one lupus patient is going to be treated like another, kind of like scleroderma. It runs its own course depending on the person. So teaching is going to be about the disease process. It's going to be about using sunscreen daily. Again, they recommend a 50 SPF and to apply that every single day. Energy conservation. Take rest periods, prioritize your activities. If you are starting to feel run down, take a break because you don't want to push your body too hard. You can end up with a flare. You're going to want to keep up to date on immunizations. This is kind of interesting. Avoid oral contraceptives in patients with lupus who have migraine headaches. Patients with lupus, specifically with the manifestations noticed, have an increased risk of hypercoagulability, which may be heightened by the use of oral contraceptives. So if you have any of those signs or symptoms, Migraines, Raynaud's. Raynaud's is where the microvessels in the tips of the extremities actually overreact to cold, the temperature, and they close down. So the tips of your fingers turn purple, they can turn white, you lose feeling. It can last for a while or it can go away as soon as you get into a warm environment. But basically it's the body reacting and it's protecting the core and it's shutting down all those micro vessels and shunting the blood to the core to protect the core. And then you have like a hypoxic situation going on in the tips of your fingers, tips of your toes, sort of thing. We have a picture on it on our ticket to class slideshow, so you'll get to see a picture of that. So the oral contraceptive thing related to lupus, and if they have migraines or Raynaud's, that has NCLEX written all over it, because that is a weirdo thing specific to lupus, right? So anything that is super weird, that sets a disease process apart, or something about a med that sets it apart, anything like that is stuff you're going to want to pay extra attention to. And then, of course, if there are referrals to nephrology, pulmonology, cards, whatever, we're going to help with that process. Now we are talking about gout. Gout is a disease in which monosodium urate crystals are deposited in joints, bones, and soft tissues, accompanied by inflammation. Most commonly found in males, 40 to 60, and females, 55 to 70. Risk factors are related to obesity, hypertension, eating large amounts of meat and seafood, and consuming large amounts of alcohol, in particular beer. So these things, meat, seafood, and beer, produce in the body a lot of purine, right? And what happens is the purine ends up increasing uric acid production. Uric acid then turns those crystals, the crystals like gather in the joints basically and cause these gout flare-ups, okay? Gout can also be caused by use of thiazide diuretics. Hyperuricemia. So this just means too much uric acid in the blood. So if you have gout, then you definitely have hyperuricemia. But you can have hyperuricemia and not have gout, okay? So just kind of make that differentiation. Signs and symptoms. So gout attacks typically resolve after several days or weeks, even if left untreated. So even if you don't go get help, it'll usually resolve on its own. However, gout can become chronic, and it can become a chronic inflammatory destructive arthritis. So just remember, gout is an accumulation of these uric acid crystals in the joints, and these crystals are super sharp. And so they are in there just tearing up your joint, causing all sorts of damage, right? It's super painful and it's destructive. You can have acute, intercritical, and chronic gout. Acute gout usually involves one joint, characterized by acute onset of pain, redness, and swelling. A lot of times the joint in the big toe is the joint that we see gout occur in. I'm not sure why. I don't know what that pathology is there, but you'll see gout in the big toe. Intercritical gout is the asymptomatic period between gout attacks. So intercritical is when you're not having any problems. And then if gout is left untreated, the attacks become more often. With a shortened intercritical period. So basically, if you don't go get treatment though, the problem is your attacks become more frequent and you get less rest period in between, right? So the bulbous formations that form around the joints are called tophi, all right? That is specific to gout. So chronic tophaceous gout is characterized by repeated attacks of many years, leading to the production of tophi, uric acid deposits or nodules in the joint, and joint destruction. About 80% of patients present with the first attack of gout affecting a lower extremity joint, typically the first metatarsophalangeal joint. This is going to be your big toe. The severity of the attack typically peaks at 12 to 24 hours after onset. Patients may experience gout flares that are provoked by a variety of dietary and physical factors. These factors include trauma, surgery, fatty foods, use of drugs that affect serum urate concentration, such as diuretics, thiazides in particular, and alcohol consumption, in particular beer. Triggers for gout flares may also include immunizations. Gout flares are typically monoarticular, so occurring in one, and occur in the lower extremities. A presumptive diagnosis of gout may be achieved by combining objective, subjective, and lab data, but the definitive diagnosis can be made only by observing crystals in synovial fluid or tophaceous material. So they're going to have to draw some of that fluid out and see if you have uric acid crystal buildup, right? We don't need to use x-rays, but they may use x-rays to look at like the joint erosion and soft tissue nodules and stuff like that. So they may use x-rays just to look at the damage that's been done, but x-rays are not needed to diagnose. Treatment, non-pharm, weight management, stop drinking beer, stop drinking alcohol. You're going to have diet stuff. Diet related to avoiding meat and seafood. They can actually splint the affected joint to help with protect the joint and alleviate pain. Pharm treatment just depends on what stage the patient is at. Acute gout management is focused on pain relief and reduction of inflammation. So again, with our NSAIDs, we have indocin and colchicine. Those are used in relation to working on the uric acid crystals, right? Steroids again. Let's see. Allopurinol is actually a uric acid lowering agent. So you may see that, allopurinol, uric acid lowering agent. One thing to really remember though is that acute gout, so if you're having a flare, we do not use a uric acid lowering agent like allopurinol. Believe it or not, by lowering that uric acid level rapidly, it can actually provoke or worsen the gout attack. So allopurinol is something that you might put somebody on after that attack has kind of resolved in severity. So, and that's a weirdo thing, right? That we can't use a uric acid lowering med during an acute attack. You know, no allopurinol, no, it's a uric acid lowering med, but we can't start it during an acute attack. We need to wait until that severity has resolved because it can actually exacerbate that attack. This is table 20.10. Slide 56. This just talks about typical presentation of gout patients. So take a look at this, okay? Talks about what we may see related to labs, subjective, objective, and x-rays. This is a picture of gouty joints. See those fingers? See how they're just bulbous? That's the tophi, okay? Those are called tophi, T-O-P-H-I, and that's related to the destruction, the inflammation, and the buildup of the uric acid in those joints. And then that second picture is uric acid crystals. Look at those. Look how sharp they are. Think about how painful that is and the type of damage that is going to do to the inside of your joints, right? Craziness. So assessments, obviously, we're going to monitor uric acid levels. Just remember, if you have gout, you're going to have hyperuricemia. So that is increased uric acid in the blood. But again, just because you have hyperuricemia does not mean you have gout. We're going to assess for tophi. Tophi indicates advanced gout. Okay, we're going to look at the joints. Are they swollen? Are they red? Are they painful? We're going to assess pain levels. Actions, we're going to give meds as ordered. Teaching, a lot of that's going to be diet, right? We're going to talk about beer, alcohol. We're going to talk about education related to purines, what that even means. Avoiding meats and seafood, red meats in particular, and organ meats are apparently the most purine producing. We're going to talk about use of uric acid lowering agents, what to look out related to gout flares, and reporting gout flares to your physician. All right, now we're talking about fibromyalgia. Fibromyalgia is the most common cause of chronic musculoskeletal pain in female individuals between the ages of 20 and 55. Fibromyalgia is a chronic pain disorder of soft connective tissues that is characterized by widespread pain and other symptoms such as insomnia, fatigue, stiffness, and cognitive dysfunction. The etiology and pathophysiology of this disorder are unclear, but current theories include the abnormal processing of stimuli by the central nervous system causing normal pain signals to be amplified. I will tell you right now, this is not in the book, but this is the most current train of thought, is that fibromyalgia is autoimmune and that it's autoantibodies causing the pain related to the fibromyalgia. The weirdo thing with fibromyalgia is that there is no physical sign or symptom causing this pain. You will not find anything physical that can be attributed to this pain. And so they've always thought it was CNS related. You know, for some reason your body is either magnifying pain symptoms or interpreting stuff as pain that the brain would not normally interpret as pain. So they really have gone with a CNS, viewed this as a CNS problem, but the latest research is indicating that it's autoimmune and that it's autoantibody driven. So I suspect by the time you guys are nursing and seeing treatment, you're going to see some changes to how we deal with fibromyalgia. Treating it more like an autoimmune disease versus something that is CNS related, because right now we use a lot of psych meds related to fibromyalgia, because we're trying to calm down those nerve impulses and whatnot. So it's a lot of psych meds. So it'll be interesting. As of now, our book still has it as being CNS related, so just kind of an FYI, but it tells you how things can change in the medical field, right? Diagnostics, you know, lab testing, not really indicated. Fibromyalgia is one of those things that when it's being diagnosed, what they do is work on ruling out other causes. So they look for a physiological reason that the person may be experiencing the pain that they are saying they are experiencing. So we rule out other things. So we may do labs, but it is to rule out other stuff. We may do x-rays, but it's to rule out some sort of physiological cause. All right. Physical exam of the patient is essentially normal with no evidence of joint or muscle inflammation. According to the 2012 criteria, a patient satisfies fibromyalgia criteria if the following 3 conditions are met. So you only have to meet these 3 conditions to be diagnosed with fibromyalgia. So widespread pain index greater than 7, symptoms that have been present for at least 3 months, and there is no other disorder that would explain the patient's symptoms. Okay, so that, I mean, that has changed too, because it used to be, if you ever hear somebody talking about tender points, that is related to the old diagnosing criteria for fibromyalgia. There was like, I think like 18 tender points, and you had to have like 14 tender points, whatever. But obviously, diagnosing criteria has changed, and that's good, and that's based on more, what we are understanding about the disease process itself. So treatment, non-pharm, all the things we've been talking about, right? Strength training, aerobics. The one thing that is included in the book at this point is cognitive behavioral therapy, because they really do, they're really thinking that it is anxiety. It can be anxiety induced, right? And if you think about anxiety, what hormones go on in our body when we're anxious, right? So if we have somebody who is anxious a lot, and then we have a CNS system that may be misinterpreting pain signals, working on that anxiety would be helpful, right? So that's why we see cognitive behavioral therapy with fibromyalgia. Let's see. Farm, kind of all the things we've been talking about. The other things they throw in is like the psych meds. We do not use opioids related to fibromyalgia because there is no physiological manifestation for the pain. So the risk of using opioids related to them being habit forming, and the fact that research has shown that they really don't help with the pain anyway. So just remember, opioids not used with fibromyalgia, okay? Haven't been shown to be helpful. Vitals may be increased related to pain, anxiety, that sort of thing. If you're in constant pain, you may be depressed, right? So we're going to want to assess the patient's affect. This is another one where like the psychosocial aspects come into play, and we may want to offer resources accordingly. Actions that we're going to take: administer meds. Another thing they use with fibromyalgia is anti-seizure medications. And again, that's because that is how they work on the CNS system. We're going to want to talk about sleep, our 8 hours of a night and all of that stuff. Heating pads for painful muscles, cold packs for joints. Teaching, take your meds as prescribed, right? These are some very serious medications that can be harmful if taken inappropriately, or stop started, that sort of thing. So make sure they know how to use their medications. Participate in regular physical activity. We're going to want to talk about coping skills, right? What are their coping skills? Are they healthy coping skills? Or do they go and sit on the couch and cry every day? Like, how are they doing? Could they use some community help? Could they use some counseling? And something like this where there's no physical cause, do you think there could be definitely instances where maybe family, the partner, the kids, like they may not understand. Like, there's really nothing wrong with you. How can you be in pain? This must just be you not wanting to spend time with us, right? So there can be a lot of psychosocial aspects related to this. So counseling may not just be the patient, but maybe the whole family together as a unit, individual, the partner, whatever the case may be. Because it can be hard for people to understand how in the world can you be in debilitating pain, meaning that it is affecting your daily life when there is no physical manifestation related to this. So psychosocial is huge with this. And that's it. We made it. Not bad. So 2 hours, 25 minutes. All right. Let me know if you guys have any questions. Thank you.